So we're on to the presentation. I'm very delighted to introduce Dr. Kathleen Myers. She is a Professor Emerita at the UW in the Department of Psychiatry and Behavioral Sciences. She took the leap to finish off it back in June, so she hasn't been retired that long, and I think she's still dabbling. We're lucky to have her today. Prior to retirement, Dr. Myers was the Director of Telemental Health at Seattle Children's Hospital for 18 years. She conducted the only NIMH-funded community-based RTC of the effectiveness of telemental health, which demonstrated the benefits of both teleconsultations to primary care providers and short-term telemental health services directly to families. Dr. Myers also chaired the Telepsychiatry Committee of the American Academy of Child and Adolescent Psychiatry for 15 years, remains a member of the American Psychiatry Association Telepsychiatry Committee, with whom she developed the Toolkit for Child and Adolescent Telepsychiatry. I think Kathleen, you were also involved in the Psychiatry Special Interest Group for the American Telemedicine Association and developing some white papers there. And I could go on and on. Dr. Myers has been involved in telepsychiatry with children for many, many years, way before COVID hit, and she's really been a leader nationally in the field, is recognized nationally for all of the work that she's done. So I'm very delighted that she could step out of retirement for a couple of hours to join us today and share with us all of her knowledge and experience. So Dr. Myers, I turn it over to you.
Thank you. So for those of you who may have attended some of the other sessions, some of the material may be redundant, but I will try to keep it within the context of children and adolescents, but some of it may be just useful in general going forward. So here are the objectives. You'll learn about conducting telemental health with kids, and I should say I probably talk predominantly about telepsychiatry, but some of you may not be psychiatrists, and most of the information will apply across disciplines. But if there's something specific to telepsychiatry, I will try to note that. Attendees will also learn about the evolving evidence base and curriculum competencies. You'll learn about privacy, safety, legal considerations, about establishing a home-based telemental health practice, and probably most important about establishing a therapeutic space with youth during home-based as well as in-clinic telemental health. And then I will send to Kara at the end a checklist for training, for people who want to train trainees, but also for setting up just own practices. So learning objective number 1 is the need for telemental health with kids. And things have progressed with kids, so we are up to date with what adults do as well. And as you'll see over here, excuse me, there are multiple technologies. This is actually a legacy-based or fiber optics-based system that only folks at medical centers or university centers would likely have because it's expensive. It's not home-based, but we use it for certain centers that are able to afford such technology. This is a desktop system. We also do this on iPads, and I don't have in here a picture of doing it on an iPhone, which I don't think is great for kids, but we do what we need to do to get services out to families. So this is a map, 2012, of the underrepresentation of child and adolescent psychiatrists across the country. And you can see the middle of the country is pretty blue, meaning there aren't many child and adolescent psychiatrists. So one of the approaches of the American Academy of Child and Adolescent Psychiatry and medical societies is to try to recruit more people into child and adolescent psychiatry training. And while there's been a bit of a tick up recently, there's really still a great shortage. And even if we recruit a lot of child and adolescent psychiatrists, you can see what the actual representation is. They're along the coast. People do not go to the middle of the country. And so even if we have more, we're still going to have a large part of the country underrepresented, and telepsychiatry can reach them. But even within Washington and the Pacific Northwest, or even on the East Coast in major centers like Massachusetts, New England is underrepresented, and we have lots of need. The other thing is, as COVID probably is going to teach us, it's not just underrepresented rural communities that need telepsychiatry. Your next door neighbor, the schools, other people will want these services, and people are juggling a lot of things, especially post-COVID, trying to get back into the workforce. They won't have time to travel into a clinic. It's quite inconvenient. And so we anticipate that more and more people will request to do this from their homes. So that was quick. Learning objective number 2 is reviewing the evidence base. This will also be quick. So the reason is just that I'm going to summarize things. And if anybody really wants a table of the studies that have been done with child and adolescent telepsychiatry, I can send that. But one of the studies, just to do truth in lending, is that the literature would tell you, if you read book chapters or summary papers, that the efficacy of telepsychiatry with adults is well proven. I would say that's not actually true. In a way, it may not matter at this point, but most of the studies have been non-inferiority trials or equivalency trials, and this shows that doing telepsychiatry is equivalent in outcomes or acceptability and satisfaction to doing in-person usual treatment. The only thing I would say is most of those studies were done in the early years, and they were not necessarily doing outreach to distant communities. They would set up a telepsychiatry system in the clinic down the hall and deliver care that way. Well, one of the problems with that is people still have their transference to or acceptance of going to that clinic. A lot of those studies were done at the VA. The best studies that were done reaching out to the community were through the VA. And so in terms of those who you may be rigorously looking at research, I don't think there's a lot of rigorous research that's been done. And in child and adolescent psychiatry, that's the same thing. The feasibility studies clearly indicate that it's possible to do all sorts of treatment through telepsychiatry, and it's acceptable to referring doctors, to other stakeholders, to families. Most would say, I'd rather see my doctor in person, but they're perfectly happy. Part of that is the convenience of not having to travel a long distance. There's only been a few studies that are randomized controlled trials, and that's been done for tics, obsessive compulsive disorder, psychosis, ADHD. There were small studies, but clearly show that clinical outcomes are as good as doing in-person care. And then there's been only 2 major randomized controlled trials. One was what we did at Children's with ADHD, reaching out to multiple communities in Washington and Oregon, and then parent-child interaction therapy done by John Comer at Florida International, which showed the efficacy of doing that in the home. So I say this only so you'll know that the evidence base is not as solid as some people would say, but it doesn't matter at this point. The truth is, no more studies will probably be funded because the use is so outpacing the evidence base that telepsychiatry gets included into other studies that are looking at other things, and we're just moving forward. But I just wanted to do a little truth in lending. Okay, so the third objective is the legal, regulatory, and ethical issues specific to working with youth. So most of the issues really are the same as working with adults. I'll try to make this a little bit more youth specific. But one of the things you'll want to do is verify patient identity and location. This is especially true if you're doing home-based work. So if you're working with a mental health clinic or a PCP's office, they will do this for you. But if you're at home, you need to somehow make sure the patient is who they say they are, and make sure you know where they are and tell them who you are and where you are, not your actual address, but that you're in Seattle or you're in Snohomish or something. You also have to be aware of federal, state, and professional organizations' positions on telehealth. So COVID really put this into the forefront of being an okay thing to do. What will come after COVID is not clear, but the push from organizations is really to say, change the guidelines and get this to be easy to do everywhere. So one of the things is that federal guidelines may not be the same as your state's guidelines. And it's good to contact your professional organization as a start to find out if there are any discrepancies. The biggest discrepancy may be on prescribing controlled substances, but there may be other things they want you to do. And I just learned from Cara actually that the state passed a law that if you're going to do telehealth, especially I suppose at home, you should have some training. You just need to look into these things. Consent, So, you know, the law would say that a teenager could come into your clinic, in-person clinic, and request services without parental okay. Well, of course, the parents may get billed, then they'll find out. But that may be legal. But if you're doing it in telepsychiatry, it's not illegal to do it that way. But I would highly recommend you don't do that, that you make sure that the youth and the parent both agree for services and sign some sort of consent, especially if you're doing it at home and the youth is going to be home alone without the parent. And it's a rural area, there are going to be guns in the home. You need to figure out how to do this with the parent giving consent, knowing what's going to happen, and knowing when the session is occurring. So your consent form should probably include parent and child. There are consent forms available these days, and you may just need to alter it to make sure you have both. Then you want to be sure that the youth knows and the parent that they have a right to in-person treatment. This may seem obvious, but it's come up in multiple areas that they need to know that this is just an option. And then this mandated reporting may vary by jurisdiction. The biggest example I have of this is someone in Kansas City, in Kansas, seeing patients across the river in Missouri. And the reporting, like on child maltreatment or other things, could be slightly different. So if you're practicing across states, you really need to know the guidelines. They may even vary across county. So just check to be sure if your patient is not in the same place as you are. So in session risks, you want to not leave or disconnect without mutual agreement. So if you have a kid that's angry on the other side, they may try to disconnect. Or if you have a particularly out of control child or caregiver, it could happen accidentally. You need to have a way to make sure you can connect with them by phone to make sure everything's okay. This is also the issue with backup plans should your technology fail. And I would give you a personal example here of doing some work with Ketchikan, Alaska. So I asked to make sure they give me the number of the landline that was in the room. There was no landline. They put a landline in, and then when I called, because the technology failed, it was forwarded to the front desk and they were at lunch. You need to make sure that these systems, these backup systems, are working. And if they're going to give you a telephone number and you're seeing the child on their cell phone, and they give you that number, that may also cause problems. So make sure you have a backup system. For most people, that's a phone. Risk reduction, firearms, all that stuff you do if you're doing an in-person clinic. People in rural communities do not have the same sorts of views of things that we at coastal urban centers have. They are going to have guns. The kids do know where the ammunition is stored separately. You need to address this with families. Get the best risk reduction you can do. They may say they're going to remove arms. They may say they're going to lock them up. They may say all sorts of things. But set up your practice so that you know what the risks are and what you're willing to deal with. Then you need to have a plan for behavioral and medical emergencies. Some other folks may have already told you that if you're in Seattle and your patient is in Kalispell, 911 will not work. You have to have their emergency numbers there. So I was told, but I haven't tested this out, that if you call 911 here, they will forward you to emergency services in Kalispell. Check it out ahead of time for your practice. And then there's prescribing controlled substances through telehealth, which is legally forbidden, and I'll go into that more later. So the fourth learning objective is setting up a therapeutic space. And for this, we're going to do mostly pictures. So here are the main things to think about. You have to have specific room requirements set up ahead of time. Don't just leave it to your site or your family to decide how they're going to set up a room or which room. So families will typically choose the kitchen or the family room or living room, which does not give privacy for the rest of the family. Even though they say it's private, all sorts of things happen. And this has happened to me multiple times. Or if they're in the kitchen, they may decide to do this while they're having dinner or snacking. These are not okay things. You have to have an agreement ahead of time. If you set this up with telepsychiatry in a mental health clinic or a primary care clinic, They may put you in a closet where there's not enough space to do a mental status on a child, or a conference room that's so large the child's out of control. And I got to say, a bad thing that happened to me once in a primary care practice, it was a conference room with a large table, and the child was hyperactive and the mother was passive. The child went off screen. I didn't see it. And it was a difficult session. And the child took a marker and wrote all over the screen, the projection screen, and ruined it. And I didn't see it. I found out later about it. They did not charge me, but you really want to be able to see the child at all times. So you need to tell them what you need for room requirements. You want to have everybody in the room on screen. This is part of what's called telepsychiatry etiquette. Occasionally, if they have a smaller screen or inferior sort of system, you may not see everybody. You need them to still identify themselves verbally, and when they speak, come into the screen so you see them. If they're off screen, it could be an adult prompting the child, or you don't know who that person is or how stable they are, so they should be on screen. A typical room for a kid is not just the kid, it's the kid with at least one other adult, and generally planned for 2 adults. They may bring a teacher or both parents or a sibling. I should say, I didn't include this here, but it's not untypical, just as it is in our clinics, for parents to show up with their 3 younger siblings because they don't have childcare. And you're just going to have to get through the session with lots of other activity going on. It can be difficult, but it's doable. If you have a lot of younger siblings and the clinic there does not have a waiting room for them, they can't go out, they can be disruptive. You're just going to have to work around it in the best way you can. I would say sometimes we have to be creative. In setting up a room, you want to minimize decor to prevent camera distortions. Even plants can be a problem. So if you'll see my setup here, you can see a bookcase here. But what's not good is and that's not even that good, but it's nice to have a neutral background with not a lot of clutter in the background, and you don't want to be lit from the back. You want to be lit from the front. Artificial lighting is most consistent. If you have natural lighting, it varies through the day. Your view will vary during the day. I'll show you an example of this. You need to get fans, air conditioners, pets out. When I first started doing telepsychiatry at Children's, I was in a Quonset hut and you could hear everything. People walking outside, going to lunch, the traffic as people came into the center. These things are really annoying and minimize your ability to relate and stay on track. You want to also reduce hard surfaces. So a lot of industrial sorts of rooms with hard desks, other hard surfaces. If you've got a room like that, throw in some pillows or rugs, some tapestries on the wall. Otherwise, you're going to have an echo. The thing I ask people to do is to set up a chair sitting where they would like in the room, about 8 to 10 feet from the camera, and then to take a selfie or some picture and send it to you, and see if it's adequate so that you can see the whole child's body, but also sufficient to see their face so you can look for dysmorphia, tics, affects, stuff like that. It's good. You really should do this ahead of time. They may also put that chair so that the camera is facing a window. You'll never be able to see them adequately during certain times of the day. It's ideal with some of that legacy equipment I mentioned with the first slide to have what's called a zoom and pan tilt camera so that you can operate the camera at the other site. This is why to have legacy equipment, so that you can follow the child around the room. You can zoom into their face versus their extremities. But on consumer-based systems that you'll have at home, you're not going to have that luxury. There are a few systems that have that, but most of them are not sufficiently priced yet. But that is the future. You will have it on consumer-based desktops, laptops, etc. And then you want to set up your camera to optimize eye contact and relatedness. So let's see if we have pictures. So this is David Roth at Mind Body Clinic in Honolulu. He's on the Telepsychiatry Committee. And you can see that lighting with #1 has shadows and you can barely see him. #3 is also not casting shadows, but he's not adequately lit, although he has a nice neutral background. In number 4, he's illuminated from the front, but it's quite focal, and only 2 is really giving you an adequate sort of view of him. So lighting really matters. Now here's a picture of, it looks nice. It's a nice view of this child. This window, when I had this sort of setup, this is not me, and at 3 o'clock in the afternoon in the summer, it was west facing, and I would totally be wiped out. And so this little picture-in-picture function in here is available on most consumer-based systems. And it's nice to both make sure you're still on camera, make sure to see the vision or the view that the child may have. A floating head is not good. You want to have them see more of you, but also tells you what the lighting situation is. So a lot of light like this is not good, especially if it's west-facing. Also, I guess, early morning. There's also a question about, she has some nice soft fabrics in here, which is good, but this hard desk may or may not cause echoes. You're just going to have to figure that out as you go along. But this child has a nice neutral background, a nice soft chair to absorb sounds, but actually we'll go over this more. You can only see her from the chest up. Do you know whether or not she has cerebral palsy and sort of legs or arms that are not the same size? Should she have tremors? You can't tell. So this is not an optimal sort of view of the child, and these windows are not good. I'll show you this picture for another reason later. So this is an individual session. This looks quite nice. This is actually a very old setup. We don't have these sorts of cameras anymore. But the child is well framed from her affect or facies down to her extremities. Nice soft surfaces, a nice neutral background. The plant may and may not cause problems, as this plant may or may not. But she's framed well. It's uncluttered, nice neutral colors. And you can really see the child and do a good mental status. This is also important if your child's on meds and you want to observe what happens with the medications. So here we have a child with 2 adults, which is the right size, and they're framed nicely, and they've got a beautiful neutral background and some nice surfaces. This looks like it has some sort of grass cloth or something on it. But the problem is you really cannot see the child from the shoulders down. So if you could get rid of this big desk and he could move around a bit, you could see better. But the desk is nice in terms of having him do some writing assignments, drawing pictures to share with you. So again, you're going to have to figure out yourself what's going to work. But the framing's good, and it's uncluttered, and the child is very nicely centered, and you can see his affect, tics, dysmorphia. You can also, it's nicely set up to see interactions with these adults, whether or not he's contrary, whether or not he interacts with them correctly. This also is a nice setup that you can kind of approximate eye contact here. On this picture, this is quite common. Instead of in a nice neutral room, you're in a medical clinic. The family's in a medical clinic. And so the good points are, the room's big enough, the child can move, so you can see whether or not they're hyper. And actually, in this particular clinic, this was Olympia, one of the younger kids would hide under this desk. There's another desk like that over here. The bad thing about a medical clinic, there's also over to the child's side, there's an exam table. And some of the kids like to get up on the exam table. Well, the medical doctors don't really like this when the kids make trouble in their rooms. There's too much stuff. There's other equipment kids can get into. So that's the downside. The good side is the room. He's able to move. There's a desk. You'd have him stay occupied while you talk just to the mother. You can see most of his body, see his affect nicely. So even without zooming in or zooming out, you get a pretty good view of him. There's enough room for him to do some sort of interaction with his mother. But this is a whiteboard, and this could potentially cause problems for echo, or just for, if this were in back of them, it would be a bad image of them. So this was fine in this room. They had very good, high quality equipment, so it worked fine. So this is at home. This is more like you would be doing into the home or from your own office. And there are several things worth noting. This mom is kind of leaning in. She really doesn't need to. This is a big enough frame you could see her. But if your frame is not big enough, or if they are too close up and they have to lean in, you will not get a good enough view of them. And with the iPhone, when the pandemic hit and we had to go to iPhones for many families at home, and they were close up, they were cheek to jowl, and that does not give you a good mental status of the child or their interaction or anything that's really real. They also have a cluttered background. Again, you know, this camera did an okay job, but this is not ideal, even though it's a lovely picture here. And you can get a nice view of the child. You're also not seeing their lower extremities. The camera here is nice. I'll come back to this, but you see how the camera is. It's actually on a good plane with her eyes, even though the image here is a bit below her eyes, but this actually is better for the family thinking you're making eye contact with them. So this is an at-home session. The good and bad parts of each of these. So this is so sweet. The child, of course, as all kids are, is just enamored by the technology. The room's big enough so when you want to talk to the mother, the child can get down and play. The bad thing is that some of these toys may make a lot of noise. And I got to say right now, do not have Legos. So Legos sound like a wonderful thing to see the child's fine motor skills and building skills, but they make a lot of noise as they go through the bucket looking for the right Lego, and it really interferes with the microphone. But there are some toys here, probably too many. So the bad news for a home setup especially is it's very cluttered. There's too much light coming in through here, but there are nice soft surfaces, room for the child to move. And with this setup, you probably can only see the child from about here up. So you want him to get down and move around. He's young, he'll probably nag the mother in between, but that gives you a nice idea of parenting skills and the child's ability to separate or entertain himself. This home with these very young kids has nice soft surfaces, room for the child to move around, but they're going to come back. So you want them on screen. This is a small screen, so it's going to have to be set out a little bit so you get them all if you want to see them. So again, in the home setting, you have fewer options. You're going to have to improvise a bit. But I thought these were two sort of nice comparisons. Again, toys, 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 not too many, not noisy ones. If you're working in a clinic, the child is in a clinic and you have toys that make a mess, this clinic is not going to appreciate it when they have to clean up afterwards. So you also want to limit that. You can ask the child to bring in their favorite toy from home, but you should have a few things in the clinic as well. So take-home message from setting up a therapeutic space is selecting a room that's appropriate to the clinical work. So again, if you're going to want to look at the child's interaction with the parent, you need a bigger room for them to do some interaction. If you're having a teen alone, maybe a smaller room, a smaller framing is okay. Minimize distracting decorations. You want to optimize the camera functioning, especially if you're going into the home and the family has lower cost cameras. I gotta say, for $100, you can get a really good Logitech or other camera at Amazon. But $100, $75 may be too much for some families, especially right now. Avoid reflective and hard surfaces. I didn't really talk much about this. Visual and auditory privacy and security. So again, the family room, the living room at home, probably not going to work. We've had families that have gone into a bathroom, too many hard surfaces, but they've done that, gone into a bedroom. I got to say, one session I was doing in the child's bedroom, so with the mother, it was nice and private, maybe auditorily secure. This adult male comes into the room, walks in, doesn't introduce himself, nobody says anything, and he walks out. So that disrupted the privacy, but it was really weird. He should have been introduced. I should have asked more questions. So at home, there really is no privacy. So framing of the images on screen. Oh, the other thing about doing it from your home is expect the FedEx guy to show up unexpectedly, or your computer, your printer to come on and do something. I had my mother visiting a few years ago in the winter, and she was taking a nap while I was doing a session. She got up and decided to cook, and there was all this noise. So I had to leave, explain, and have her go read. All sorts of things happen at home. The dogs are a particular issue. Siblings of the child are an issue. framing of the images, quiet toys, avoid electronics, especially when you need time with the parent. So I'll say this again, but if the mother comes in and immediately gives the kid the phone to do games while she talks, that's not going to engage the child. That is not okay. No electronics is one of the rules up front. However, if you want time alone with the parent to talk, having her, and there's no room for the child to go to the waiting room in these small mental health clinics, giving the kid the phone is great. Telepresenter, I don't know if you've heard of a telepresenter, but if we have time, I'll go over that more later. So related to setting up a therapeutic space is creating really an authentic doctor-patient relationship. And this is our 5th objective. This is the therapeutic alliance. In the early days, many people, so families were willing to do telepsychiatry in the early days, but therapists were not. They thought it would interfere with establishing a therapeutic alliance. I think there's not enough studies on this, but the fact that people come back over and over and it's becoming so popular, and when folks have done satisfaction ratings, they're very high. It is possible to establish a therapeutic alliance. So let's go over issues. So the main thing I would say is when patients are coming in person to see you in your clinic, they have the drive there, which actually is very helpful for parent-child interaction in many cases, but also a burden if you have an autistic or disruptive child. But they take the drive in, they have to park, they come in, they register, they find your office, they're in the waiting room. All this time, they're kind of adjusting to the in-person session that's coming. With telepsychiatry, especially if it's in their home, they sit down, they turn on the machine, and boom, you've all got to be on and ready to establish rapport. So they may have some difficulty settling, but you need to be prepared. There are many challenges to in-person care. There are many challenges that you encounter in telepsychiatry as opposed to in-person care. As you can't touch the person, like shake hands. You can't smell them to know if their hygiene is okay, whether their clothing is tattered, what their persona is. So you may have to adjust style to some extent to engage them. How you project to them, the volume and tone of your voice, the change of your voice when you're either sympathizing or trying to elicit certain information, and especially nonverbal communication in terms including your hand movements, your sitting position versus slouching, facial expressions, smiling, nodding agreement, eliciting more information. All these nonverbal things are very important. You must determine how you're best going to relate. In that picture-in-picture function I showed you in a prior slide, that's really helpful in terms of looking at your own affect and what you're looking like at certain times and how much of you they can see. You have to figure out how you're going to engage a child and maybe even contain the child. And actually, sometimes the telepsychiatrist can do that better than the parent for certain disruptive children. So here's the eye contact thing. So Dr. Roth in Honolulu suggests putting the image here so that it's very close to the camera. And so you're looking here, but the camera's sort of looking like this. So as close as they are, the better. But that really is not a very big picture. And so it's better to fill the screen. So usually what we would do is lower our screen a bit so that when you're looking kind of down a bit, you're actually more so looking up at times than looking at the camera. You want to establish as much eye contact as possible. Now, you can do this, but the family's not going to take care, or you look back and forth between the screen and the camera. You may do this, the family will not know to do it. So you really cannot tell on telepsychiatry the child's eye contact, which is part of the child's mental status exam. You can ask them to come up close to the camera, which I'll talk about in a minute, or you need to ask the family, does he make eye contact? And especially with an anxious or maybe autistic child, these are really important issues. Here's a great setup for the psychiatrist. So this is from Shabana Khan at NYU. This is the system they have. So the camera's in the center. So I don't do this, but most people these days are typing their notes as they do the session. So you need to have a quiet wireless mouse and keyboard if you're going to do this. But so he's typing his notes, looking at the medical record, and then looking at the session. The camera's in the middle because as you look back and forth between the image and the record, you have to make some eye contact. And you're also nodding up and down in agreement with the family. If you had the screens laterally, you would be shaking your head no, which is not so good. I'm going to show you one other of this. This is Felissa Goldstein at Marcus Autism Center in Georgia. And this is a very nice picture. The one I just showed you had a window and had decorations on the walls. Nice picture at the family site. She can see herself in the picture-in-picture, and she's got this vertical setup to look at the medical records. However, she's also online looking at stuff for them. And again, this is going to take away from your relatedness with them or looking at the camera. You're going to decide yourself how you can best do it for your efficiency and effectiveness, and best relating to the family. You may not all have this. If you can, it's a great system. Otherwise, get the camera set up as close as possible to the image of the family.
Kathleen, I'm just giving you the 1140 warning.
Thank you. So phones, is this the future? Yes, it's the future. And the future is here. So if you're doing a cell phone with a child, obviously you're not going to see much of them. They hold it like this, they're going to shake up and down. You've got to then do several things. You've got to, at times, prop it up here so you can see their full body. At times, bring it in close so you can see their affect. If you're seeing more than one person, do the phone horizontally. And then how to engage kids. So we do handshakes, high fives, fist pumps. But the greatest thing I would say is for a child at least, you want to do things like ask them to draw a picture and then hold it up to the camera for you. When they come up to the camera, you can see their face better. They can show you the picture. You can figure out their fine motor skills. You can figure out their creativity and how much enjoyment they have in sharing things with you and telling you a story, whether they can be linear. So these are easy to do things. Children love to do them while they're doing some sort of a quiet assignment. Their mother's next to them. You can still be talking to the mother to get some history. More difficult when you have a teen. And a depressed child may not talk a whole lot. So again, I don't know how this would go with doing a structured session like cognitive behavioral therapy. It's been done, but some teens may talk more because it's structured. Others may have difficulty and want more free form. However, an anxious child or adolescent, is pretty easy to engage them. Also engaging a teenager at home, there are safety concerns, as I mentioned before. Let me see, we'll skip through this. Interventions. So I will tell you quickly, interventions with child, here's that picture again. We do individual therapy, although usually you spend some time later with a mother also, or the parent. Dyadic therapy has been easily done. So this is the Autism Center from Yanis Padilla Del Mal, Seattle Children's. So whether you're directly observing and coaching the mother, or you're maybe doing consultation for a therapist, this is really nice. And since families in rural areas with autistic children really have difficulties transporting them into a clinic, this is really ideal for those families in rural areas. This is PCIT done by John Comer's group in Florida. And again, this is one's in the clinic, but this is at home. You need to have adequate space so mother can hold the child down, redirect the child, do an interaction. But PCIT, he has shown, is effective through telepsychiatry. So prescribing, this is the Ryan Haight Act again. It says you cannot prescribe controlled substances through telepsychiatry, but the law is sufficiently vague that people interpret it different ways. Many people are doing it anyhow. Many people are not. Some states like Massachusetts and Maryland, Massachusetts, Maryland, Florida, I think there are 5 states have actually put in their own laws allowing people to do it. This is only a sort of a law for child psychiatry. But I gotta say, it's like marijuana. So even though a state may say, we're going to allow recreational marijuana, it's still an infringement or illegal with the feds. So you have to figure out how to do this also. Regular meds, you can just do e-prescribing or hard prescriptions or whatever. This is actually the bulk of my practice in the past. Quite easy to do, actually. Also, I should have said, you need to still set something up with PCPs to cover, or maybe you want them to do the major prescribing. You may start it. They're perfectly fine usually to continue it unless you do something really off the grid. So I don't have a slide on this, but group therapy has also been done. So the COVID epidemic really led to difficulties, and the group of children's with Erin Gonzalez and Tyler Sasser starting to do group therapies for parents of children with disruptive disorders, for families of kids with anxiety, and actually did it quite well. They really hustled and set it up. This is also really nice if you have a child or a group of kids with something like cystic fibrosis that really should not travel in person, and to do a group session in home with them, or kids with cancer who already are traveling to clinics too often to do services in home. So school is also a very common site to do telepsychiatry, whether the kid comes to the office to do a session with you and you bring in the parent later from work, or whether you collaborate with the nurse. But this is also good if you're doing home telehealth with the family and you need vital signs and you can't get them at home. The nurse may do that during the school day. You can also get them from the PCP, but that's more of taking away from their time, and they may not be able to bill for it. This is a school consultation, therapist to teacher or to therapist. You know, you don't care so much about the background and stuff in a situation like this, but all these papers are going to make a lot of noise. But this is from University of Kansas. They have a large school consultation program. How to get paid for that is usually through the school. This is an IEP meeting. This is Tony Pignatello in Sick Kids Hospital in Toronto. You bring in maybe multiple other folks, PCP, family, other folks to do an IEP meeting or other school consultation. This is an example of the medical home, so you can be a resource to PCPs that you work with. And then this is a child at in-home therapy. Mother's collaborating with this group of folks to provide her intravenous care or whatever they're doing. Also a great service, really. I'll skip this, and some of you may or may not know about ECHO. This is the traditional telemedicine where it's a physician or a provider to a family is still the traditional one-to-one model. But if you haven't heard about ECHO, you take a team of folks at the hub site who gets a bunch of PCPs or other folks at the spoke site together, maybe multiple spoke sites, and then they take that expertise to multiple families. You really leverage one group of folks to serve many. And this is something that's actually more implemented in the medical community than in the psychiatric community, but it is going at several sites. Maryland, and this is ECHO at University of New Mexico, developed by Dr. Aurora. He's a hepatologist, not a psychiatrist. But this is Dan Alicata here, who's doing this at the University of Hawaii. Multiple professionals consulting to multiple other professionals at other sites, other islands. So my last thing I will say is, it's ideal if you get to know your community if it's distant. If you have a one-to-one in your own community, this isn't as important. But if you're going out to distant communities, I would visit the site, meet the stakeholders, find out what they want, find out the culture of the area, vacation in the site, develop a hybrid model where you're working with the PCP to do the care. A telepresenter is somebody that the site hires to get vital signs, present the case to you, take calls in between. This is obviously not possible if you're doing in-home telehealth, but if you're doing consultation to a distant center, telepresenter is helpful. It's an additional expense for the center, but this really helps things go well. Be aware if it's a rural community, your family coming in may know the telepresenter. It may be a relative, it may be the next door neighbor. So there's some ethical issues you will need to address in how to do that if they know the telepresenter. Ask families about their life. Go online and learn about the school, learn about something that's going on in the community so you can engage the family around it. Since I'm running out of time. So for staffing for in-home services, obviously you can't do this. You may need to get vital signs and stuff, the school nurse, the PCP collaboration, 911 I mentioned already. get all this information for the family, and I will send Kara the care protocol so that you can document this stuff and know how to call if there's an emergency. Tools and resources. We have developed a telepsychiatry curriculum that will be most appropriate to those of you working in academic centers or training folks. We also have this toolkit. You can go online, and there's more and more information being put up on it, but right now there's also a video toolkit where each of us presents something. This is an article relating to the curriculum, but this relates to the care protocol I mentioned that I will send to Kara to give to you all. And then she already told you about the telehealth resource centers. I don't know if anybody's interested. There's this thing called board certified telemental health. This involves multiple providers. So this is not a real board certification, but there are different institutes providing services. The one thing I would say is that curriculum I mentioned was funded by the American Board of Psychiatry and Neurology. And if they funded it, you do wonder if they have in mind to develop a board certification in this. So for all of you that are interested, get in now so that when they develop a board certification, you can be grandfathered in. So here's the truth and full disclosure. Most telepsychiatrists make do with what they have. Most work does not have ideal situations. I've done this in a closet, in all sorts of situations. Some people do it in a family car to get the privacy. The pandemic has taught us that we can be creative and join with our patients in creating an authentic doctor-patient relationship. Just do it. Thank you.